to our short Delirium Awareness training video. My name is Donna and here are my colleagues.
Hi, I'm Nikki.
Hi, I'm Hayley.
We'd like you to watch this video before we visit you in person on the wards at Hinchingbrooke Hospital, where we will be happy to answer any questions you might have about delirium.
First thing we would like you to remember is that delirium is a medical emergency and should always be treated as such.
There are countless possible causes for delirium, and there may be more than one cause present at the same time. Often in older people there will be several contributing factors. For example, an older person who has had surgery for a fractured hip may be delirious due to the effects of anaesthesia, trauma, pain, sepsis or low haemoglobin.
When considering a diagnosis of delirium, we should be looking for a sudden change in presentation, which might be changeable throughout the day and night. The person will also be difficult to engage, and their attention may seem to wander. There must also be evidence of either confused or disorganised thinking, or an altered level of consciousness. This might mean that the person is excessively sleepy. This is called hypoactive delirium, or more active and agitated. This is called hyperactive delirium.
As mentioned earlier, it is important to remember that delirium is a medical emergency, which, unlike dementia, may be completely reversible in some people. Unfortunately, in older, more frail patients with lots of other physical health problems, and especially those already diagnosed with dementia, there may only be slight improvement as the underlying cause of the delirium is treated. Recovery is slow and may take weeks, if not months. Even when that person has completed their medical treatment, such as antibiotics or blood transfusions, and they are thought to be completely medically fit, the symptoms of their delirium may persist.
It is vital, therefore, that you identify any sudden change in a patient's presentation. Try to talk to family and carers. Establish a baseline. What is their normal behaviour? What level of assistance do they usually need, etc. Are they more sleepy than usual, more confused, or possibly saying things that don't make sense? Is this a change?
Now we will consider the most helpful ways you as nurses and carers can help a delirious patient in hospital. Routine is very important, especially in helping patients identify between day and night. This can easily be facilitated by using day and night clothes and simply telling the patient. For example, saying, "Good morning, Mrs. Jones, it's 10 o'clock on Friday morning. Are you ready for your wash now?" We've also found that rushing a delirious patient will probably only make them more agitated and confused. Please take your time and explain clearly who you are, where we are, what you are going to do for the person, and why you are going to do it. You should do this on each interaction with the patient. Slide 7 identifies lots of things that you as nurses and carers can do to help the person with delirium get better. Please read this slide carefully and try to incorporate the suggestions into your normal care routines.
And lastly, we would strongly suggest that delirious patients are never moved between wards, or even within a ward, as this can be extremely disorientating and frightening for a patient who is already confused and vulnerable. Sudden moves, especially at night, are often a contributory factor in agitated and aggressive incidents. Good basic nursing care is essential. For example, maintaining adequate diet and fluid intake, preventing constipation and not routinely catheterising patients. Research has also shown that patients who are active and mobilised regularly whilst delirious recover quicker. So try to incorporate regular interaction and exercise into your patient's daily routine.
We hope that this short video has been helpful, and we look forward to seeing you on the ward soon, where we'll be happy to discuss further and answer any questions you might have.